A very good morning. Today we begin with the second session of Mixed Bags MCQs, which are very important for the NEET PG examinations. Yesterday we discussed a few concepts, a few MCQs, and today is the second session. It'll be a 1 hour session. Before that, let me tell you about the NEET PG free test calendar for the month of March. Okay, so today is 30th of March. Today at 7 p.m. there is an educator curated test series, that is radiology by Nikita Nanmani, today at 7 p.m. Tomorrow at 4 p.m. there is a previous year test series, that is mixed bag 5. Okay, so these are completely free. They are on the Unacademy platform. What you need to do is to just download the Unacademy learning app and you can get access to these test series free of cost. Okay, so please do take advantage of this particular opportunity. Next, there is a previous year's question bank. Okay, and this will be held on March 23, 2022. This is already over actually. Then going on to this NEET PG Lite, Unacademy Lite. Now this is something very interesting, which is basically for PG students basically for people who are preparing for their NEET PG test series. Okay, so just 1 second. Just switch off this. This may disturb us. Yes, so this NEET PG test series, it's a subject-wise test series, which is including subject-wise test series for all the 19 subjects. There are system-wise test series for all the 19 subjects, full-length mock test papers, previous year's question papers, and test series curated by the top educators. Everything of this is available on the Unacademy platform under the name Unacademy Lite. So this is basically only a test series based program. So this is a very important announcement that if you do subscribe to Unacademy between March 28th to 31st, so you have only 30 and 31st left now, we get an additional 20% off on the Plus and the Iconic subscriptions. Okay, so like for example, if the initial Plus price for 6 months was 22,500, now it will be available for 18,000. And the Iconic subscription is something that is a combination of Unacademy with Prep Ladder. Okay, so earlier the combo subscription would have cost you 40,000, but now it will cost you 32,400. So when you use the code MENTOR, please remember the code MENTOR, MENTOR is the code. The code MENTOR, if you use, you will get an additional 10% off. Okay, so this is something very exciting. Please do take advantage of this offer. Now, this is something very important for the people who are in their MBBS. So this is MBBS Prof 1. It's an in-depth comprehensive concept coverage, which is very important in the early years of MBBS. Also, there will be clinical integrated sessions. There will be answer writing guidance sessions, which will be very useful for theory examinations. And clinical integrated sessions will help you with your practical examinations. There will be subject-wise tests every Saturday, followed by discussion sessions on Monday. Full subject tests will be available at the end of the subject completion. Live interactive classes will happen with the top educators. There will be doubt clearing sessions. Recorded sessions will be available in case you miss live, and PDF notes will be available for each session. So this is something really useful for people in their MBBS course. Now there is a doubt clarification series. It's an exclusive subject-wise doubt resolution series, which is present only on the Plus platform. It will start off from April 6th. Okay, so you can get subscription to this particular series only by using the code MENTOR to unlock the free live session. Okay, so please use the code MENTOR. MENTOR is the code which you need to use to unlock the free live session. So what is this Plus subscription? The Plus subscription of Unacademy is the one which gives you access to both the live and the recorded classes. You learn from India's top educators, you compete in live tests, quizzes, you study on a device of your choice, and you have an access to a question bank with more than 25,000 questions. Regarding the iconic subscription, the iconic subscription is the one through which you get your access to both Unacademy and Prep Ladder. So, in addition to all the advantages that come with Unacademy, you have the clinical and the integrated essentials. You have video lectures from the Dream Team, question bank, rapid revision and snapshots, and treasures in 2021 Dream Notes. These are the toppers of the FMGE December 2021 examinations. They have done very well, and all of them are Unacademy students. You can also use the special class feature of Unacademy, which is, these are free classes. They are interactive live classes. There are polls which are put up for the learners. You have raise a hand feature in which you can talk to the educator live in the class. You can get your doubts solved in real time. You never miss a class because you are always notified about it. And there are lecture notes that are available at the end of the session. And you can access these lectures anytime and anywhere. There is this NEET PG high yield theory revision batch, which is going to be from March 30th, that is today, to May 15, 2022. It will be for a period of 1.5 months, and it will be 140 hours of revision with recorded classes, 2 grand tests fortnightly, with the presence of interactive live classes, PDF notes, and question bank with more than 25,000 questions. For the FMGE students, there is a batch which starts today and will go on up to May 30. The batch is for 2 months. And again, all the advantages that I mentioned will be present on this batch as well. Okay, so with that, let's begin with our MCQ session for today. I would want everyone to be very interactive so that we enjoy the session. Let's go to the question. Now you have a 3-year-old girl who is brought into the clinic by the father. Okay, and the father reports that she has an itchy rash on the scalp. On examination, you notice a large oval erythematous scaly thin plaque. Wood's lamp examination of the lesion demonstrates fluorescence. What is the most likely causative organisms? Is it Trichophyton tonsurans, Microsporum nanum, Trichophyton rubrum, Candida, or Microsporum canis? Can someone tell me what is the answer? Anyone? See, the clue here is that this particular organism is fluorescent under Wood's lamp. Okay, so if you know which organisms fluoresce under the Wood's lamp, I think this will be easy. Anyone would like to answer? Okay, so first of all, let's discuss what is this patient presenting with. This patient is presenting with basically tinea capitis. Correct? Now, this tinea capitis is basically a dermatophytic infection of the scalp and hair. Right? So, the description that is given to you in the MCQ stem is that there is a large oval erythematous scaly thin plaque. Okay, so this fits into the description of, anyone can tell me what does this fit into description of? It fits into the description of non-inflammatory variant of tinea capitis. Okay, for you to know, tinea capitis or dermatophytic infection of the scalp and hair can be of 2 types. It can be inflammatory type and it can be non-inflammatory type. Now, inflammatory type of tinea capitis includes Carrion, and the non-inflammatory type of tinea capitis, so inflammatory includes Carrion as well as Favus. Okay, and the non-inflammatory type includes the grey patch variant and the black dot variant of tinea capitis. Okay, now here you should understand this patient is having mainly kind of a grey patch variant of tinea capitis. Now, why am I saying that it is a grey patch variant of tinea capitis? One thing they have mentioned, it's a large oval scaly plaque. Okay, so what happens in grey patch? Grey patch, please remember, it's an ectothrix kind of an infection. Ectothrix infection means that the fungal spores and the fungal filaments, they are placed outside the hair shaft, right? They are coating the surface of the hair shaft. So the appearance of the hair will be dull, it will be gray, it will be non-shiny, right? So that is suggesting that the patient is dealing with ectothrix variant of tinea capitis. Okay, now black dot variant of tinea capitis is endothrix variant of tinea capitis. Endothrix means that the fungal spores and the hyphal elements, they are situated within the hair shaft. Okay, if the fungal spores and elements are situated within the hair shaft, what is going to happen? They are going to weaken the hair shaft. So if the hair shaft gets weakened, it will be broken off at the surface of the scalp. Okay, so those broken stubs of hair will be seen as black dots, right? So please remember, ectothrix organisms and endothrix organisms are different. Ectothrix organisms, they coat the surface of the hair shaft and they make the hair shaft look dull and lusterless. Okay, and it appears as a whitish scaly patch on the scalp. Okay, now please remember, if you correlate this with the Woods lamp examination, ectothrix variant of tinea capitis, that is the grey patch variant, is going to flourish under the Woods lamp. Okay, while the endothrix variant of tinea capitis, the organisms causing the endothrix variant of tinea capitis will not show fluorescence under the Woods lamp. Okay, so this is very important concept that you need to remember. Ectothrix will flourish, endothrix will not flourish. Okay, now if you see the organisms which cause ectothrix variant of tinea capitis, remember the mnemonic: cats and dogs fight. Okay, now where do the cats and dogs fight? The cats and dogs fight outside the house, right? So ectothrix is, ecto means outside. Okay, so remember, C stands for Microsporum canis and stands for Microsporum ordonii and F stands for Microsporum ferruginum. Okay, so these are the organisms which have caused ectothrix infection and hence grey patch variant of tinea capitis. Now, if you see here, all these are belonging to the Microsporum species. Hence, the correct answer here is E, that is Microsporum canis, because it is showing fluorescence under the Woods lamp. So, ectothrix variant will show fluorescence under a Woods lamp, right? If you go to endothrix variant, endothrix, remember TV. Where is the TV? TV is inside the house. Okay, so TV stands for Trichophyton tonsurans and Trichophyton violaceum. Okay, so these organisms, they cause endothrix variant of tinea capitis, where the fungal organisms, that is the fungal spores and the hyphal elements, they are located within the hair shaft, causing weakening of the hair shaft and appearance of the broken hair shafts as black dots at the surface of the scalp. Okay, now as you can see here that all the Microsporum species is responsible for ectothrix and it is going to flourish under the Woods lamp. Okay, now please remember that the only Trichophyton species to flourish under a Woods lamp is Trichophyton schonleni. Okay, Trichophyton schonleni is the only Trichophyton species which is going to flourish under the Woods lamp. And what does Trichophyton schonleni cause? it causes Favus, which is the inflammatory variant of tinea capitis. Okay, so let me just elaborate again. Yes, so here if I say tinea capitis can be, as I mentioned, non-inflammatory or it can be inflammatory. Inflammatory variants include Carrion and Favus. Now, we have discussed non-inflammatory variant of tinea capitis, that we discussed the black dot variant and we discussed the grey patch variant, right? We discussed these two variants. Now, black dot variant, I told you, is basically an endothrix infection. And endothrix infection is caused by Trichophyton bilatium and Trichophyton tonsurans. This all is very important, okay, for you to remember. Each and every of these organisms can come to you as an MCQ. Grey patch variant will cause is basically an ectothrix infection, and it is caused by Microsporum canis, Odoni, and Microsporum ferruginum. Correct? Now, if you see the black dot, it will appear as black dots on the surface of the scalp, which are basically the broken stubs of hair at the surface of the hair follicle, at the surface of the scalp. Grey patch will appear as dull, grey, scaly, oval patch on the scalp. If you see the carrion can be caused by ectothrix or it can be endothrix. It can be either ectothrix or endothrix. Now carrion, you remember the mnemonic men can be very red. Okay, now this red stands for inflammation. So remember, this is an inflammatory variant of tinea capitis. Men stands for Trichophyton mentagrophytes. Then it stands for Microsporum canis and it stands for Trichophyton verrucosum. So these are the organisms which cause carrion. Okay, now what is the description of carrion? The description of carrion is it's usually a solitary. It is usually a boggy swelling. Okay, there is a boggy swelling which is erythematous and is studded with pustules. So it's a boggy swelling of the scalp, and on that area, if you try and remove the hair, it is very easily removable. Okay, so it's a boggy, painful swelling on the scalp. That is the typical description for a carrion, that is inflammatory variant of tinea capitis. Favus is again an inflammatory variant of tinea capitis, and what you need to remember is that Favus is caused by Trichophyton schonleni. Trichophyton schonleni is the only Trichophyton species which is going to flourish under the woods lamp. Okay, now Trichophyton schonleni causes air spaces. Again, this is a very important MCQ. It causes the presence of air spaces within the hair shaft. Okay, and Favus is characterized by something that is called as the scutulum. So what is the scutulum? The scutula or scutulum, it's basically a cup-shaped kind of a structure which is formed by the exudates, by the fungal filaments, the hair, and you can see that there are hair which are piercing through this scutulum. Okay, so it's a yellowish cup shaped structure which is formed because of the congregation of all these elements. Okay, so remember about favus, that favus is caused by Trichophyton schondleni. There are air spaces within the hair shaft and it is characterized by the presence of the scutula. Okay, so this is again a very important topic. You need to know everything, at least what I have mentioned in this lecture. You should be very thorough. Okay, now, so this question, for those who have joined lately, the question was that which of these organisms is going to demonstrate fluorescence under the Woods lamp. So as I mentioned, the Microsporum species and Trichophyton schondleni, these are the ones which fluoresce under a Woods lamp examination, and hence the correct answer here is Microsporum canis. So for those who are present here, what is a Woods lamp? What is a Woods lamp? Can you tell me what are the contents of a Woods lamp? What is the Woods filter made up of? Anyone? What is a Woods filter made up of? Come on, you can be wrong as well. There's no problem. Omkar says it's UV light. I am asking you the contents of the Woods filter. Okay, so the Woods filter, remember, this is again an MCQ. Please remember that the Woods filter is consisting of nickel oxide and barium silicate. Okay, barium silicate and nickel oxide, these are the components of the Woods lamp. And this Woods filter is going to allow, can you tell me what wavelength is going to be allowed in the Woods lamp? Rest of the wavelengths will be filtered out. Only one wavelength will be allowed. Can you tell me what is the wavelength? Omkar, Sanjay, anyone? Okay, Omkar, 320 is, I think what you are getting confused is 320 is for the narrowband, 311 and to 320 is the narrowband. No, no, not, no. So basically, the Woods lamp is going to allow only 360 nanometers of wavelength to pass through. Okay, so please remember this. It allows only 360 nanometers wavelength to pass through, and it is useful in a number of conditions. Now, we have discussed one condition in which the Woods lamp is useful, and that is in the diagnosis of tinea capitis. Can you tell me other conditions in which you can find the Woods lamp useful? Anyone? So it is useful in the diagnosis of, okay, yes, in TS, that is tuberous sclerosis, it can be useful to identify ash leaf macules, right? Yes, ash leaf macules, they are the first manifestations of tuberous sclerosis, and ash leaf macules may not be very visible at birth, especially if the child is fair, and hence you can use a Woods lamp to delineate the ash leaf macules. Okay, so yes, it can be used to identify the ash leaf macules. Then Sanjay says pigmented patches. So it can be used in melasma. Okay, melasma presents as hyperpigmentation. Right now, how will it be useful in melasma? It can be useful to classify it as epidermal melasma, dermal melasma, and mixed melasma. Okay, now what is the significance? If it's an epidermal melasma, it will be well responsive to your treatment. If it's a dermal melasma, don't expect a very great response. And mixed melasma will partially show a response, right? So, epidermal melasma will accentuate under a Woods lamp. Okay, dermal melasma will not accentuate in the Woods lamp, And mixed melasma, which is a combination of epidermal and dermal, will accentuate in few areas and will not accentuate in a few areas. Okay, so that is how you can use a Wood's lamp in melasma. Any other use of Wood's lamp that you can think of? Sanjay, Omkar, anyone? Okay, now depigmented patches. Sanjay mentioned depigmented patches. So it is useful to differentiate between nevus depigmentosus versus nevus anemicus. Okay, now first understand what is nevus depigmentosus. The other name of nevus depigmentosus is nevus achromicus. Okay, and then the other is nevus anemicus. So both of these conditions, they look like a hypopigmented patch. Now how do you differentiate whether it is a nevus depigmentosus versus nevus anemicus? So please remember that nevus anemicus, this is again a very important MCQ, so please pay attention. Remember that nevus anemicus is not a pigmentary anomaly. Okay, it is not because of the damage to the melanocyte, it is not because of the damage to the or absence of the melanin. Everything is in place, but what is happening in nevus anemicus is that the local blood vessels in those areas, they become extremely sensitive to the adrenergic system. Okay, as a result of which these vessels, they constrict. Okay, there is vasoconstriction. So that is why that area appears pale and may look hypopigmented, look light in color, but actually there is no problem with the melanin. Okay, so nevus anemicus, it's a vascular abnormality where you have persistent vasoconstriction of the blood vessels in that area, localized area, because of their increased sensitivity to the adrenergic system. Okay, so when you see a nevus depigmentosus under a Wood's lamp, it will accentuate, while nevus anemicus will not accentuate. Okay, so that is how you differentiate between nevus depigmentosus versus nevus anemicus on Wood's lamp examination, because both of them can look quite similar. Now, what the problem in nevus depigmentosus is that, see, normally you know that the melanocyte is going to synthesize the melanin within the melanosomes. Okay, melanosomes are then transferred to the keratinocytes via dendritic processes. Now, when you have a problem, a defect in the transfer of the melanosomes from the melanocyte to the keratinocyte, you will have nevus depigmentosus. Okay, so melanocytes are not decreased. Melanocytes may be a little decreased, but not, they are definitely present in patients with nevus depigmentosus. The problem is with the transfer. Okay, so yes, Sanjay mentions that erythema occurs after stroking in nevus depigmentosus. Yes, if you stroke an area of nevus depigmentosus, it may become pink because the blood vessels there are responsive. So they are going to dilate in response to your stroking. While in nevus anemicus, there will be no erythematous response because there is persistent vasoconstriction. One easy way to differentiate between nevus depigmentosus versus nevus anemicus is to use something that is a simple procedure that is called as diascopy. Okay, now what is diascopy? Anyone? So what you do in a diascopy is you take a clean glass slide, okay, and that glass slide you place it on the apparent light colored patch, right? Now if you see that the margins of that patch are merging with the surrounding blanched skin, okay, which you have blanched the surrounding skin because you have applied pressure using a glass slide, right? So if your margins of the patch are kind of merging with the surrounding normal skin, the blanched skin, then your diagnosis is that you are dealing with nevus anemicus, because when you apply pressure with a glass slide, you are exsanguinating the local vessels. Okay, and in the patch in nevus depigmentosus, that area is already showing vasoconstricted blood vessels, it's already blanched, so the margins are going to become indistinct and it will blur, and it will kind of become flush with the rest of the blanched skin, right? While in nevus depigmentosus, when you perform diascopy, the margins or the border will not change, they are going to remain the way they are, right? So that is how you can differentiate between nevus depigmentosus and nevus acromicus via diascopy, in addition to doing a Woods lamp examination, right? Now, so that was about the pigmentary abnormalities. Now, can you tell me any other use of Woods lamp? Any other Woods lamp use? Can you tell me what will be the Woods lamp appearance in erythrasma? We have discussed this yesterday. People who have been there in the YouTube session that I took yesterday, they will know the answer. What is the Woods lamp appearance of erythrasma? Yes, Omkar, you are right. Coral red fluorescence. Coral red fluorescence is seen in erythrasma. Okay. Now, please remember that erythrasma, as we discussed yesterday, is caused by Corynebacterium minutissimum. Okay. Corynebacterium minutissimum produces a pigment which causes this Woods lamp to fluoresce coral red or coral pink. Okay. So that is how you differentiate between erythrasma and pityriasis versicolor. Pityriasis versicolor may also look like pigmented macules in the axillae, and even erythrasma can look the same. To differentiate the two, you can use a Woods lamp. In pityriasis versicolor, because of the release of something that is called as pityriolactone, there will be a pale yellow or a pale green fluorescence. Okay. So remember, in erythrasma it is coral red fluorescence, while in pityriasis versicolor it will be a pale yellow or pale green fluorescence. Okay. Then Omkar mentioned vitiligo. Yes, vitiligo is going to show a bluish white accentuation under the Woods lamp. Okay, so a bluish white accentuation is something that will help you to diagnose vitiligo or confirm vitiligo on the basis of a Woods lamp examination. Okay, the other use of Woods lamp is in porphyria. In porphyria, the teeth, the urine, they will also fluoresce under the Woods lamp examination. Okay, so it can be useful in the diagnosis of porphyria. Yes, Omkar, we have already discussed Tinea capitis, where I mentioned that the Microsporum species predominantly is responsible for a greenish fluorescence on Woods lamp examination. Okay. So, please remember, all these are the common uses of Woods lamp that we use in practice. Now, let's go to the next question. You have a 19-year-old military recruit which presents to the dermatology office with intensely pruritic papules on the trunk and the genital area. A papule is scraped with 15 number blade and is immersed in mineral oil. The following image is seen on microscopy. What is the most likely diagnosis? Look at the image that you see on microscopy. I hope you are able to see these structures. You are able to see these structures. Okay. Now, what is the most likely diagnosis? Is it tinea, tinea versicolor? Is it Pityrosporum folliculitis or scabies? Anyone? Sanjay, Omkar, Sheikh. Okay, so Omkar says it's D. That is scabies. Does anyone else wants to answer? Yes. So Sheikh is also saying it's D. Yes, both of you are right. The correct answer here is scabies. Okay, so what we are seeing here, see, first clue that they have given to you is that the patient is presenting with intensely pruritic papules on the trunk and the genital region. And what you see on this KOH mount are nothing but scibella. Okay, what is scibella? Scibella is the fecal material of the scabies mite. Okay, so you may not see the scabies mite every time. Okay, if you scrape a papule, but if you see these kind of scibella, that is suggestive that you are dealing with a patient of scabies. No, Raghu, it is not tinea versicolor. Tinea versicolor would show a typical spaghetti meatball, or it is also called as banana and grapes appearance. Okay, so spaghetti meatball or banana and grapes appearance is basically the fungal spores and the hyphal elements which give rise to this appearance on tinea versicolor. Okay, so remember, tinea versicolor will show you a spaghetti meatball or a banana grapes appearance. Tinea corporis will show you the presence of hyphal elements on the Woods lamp, on the KOH mount. Pitrosporum folliculitis will show you the presence of again the same, the hyphal elements and the spores. Okay, on Woods lamp examination, right? So the correct answer, because this is scibella, these are the fecal pellets of the scabies mite. Okay, so this is something that is very suggestive of scabies. So the diagnosis of scabies can be confirmed through detection of scabies mites, eggs, or the feces with a mineral oil preparation. Tinea corporis on a KOH mount will show segmented hyphal elements. Tinea versicolor and Pitriosporum folliculitis will show both hyphae and yeast cells on KOH mount. Okay, so that's how you differentiate between the three entities. Okay, now what do you need to know about scabies? Now, scabies again by itself is a very important topic, so I would want to kind of elaborate on it. Can someone tell me what is the causative organism of scabies? What is the name of the causative organisms of scabies? Anyone? What is the causative organism of scabies? Anyone? Omkar, Raghu, Sheikh. Okay, Omkar, it is Sarcoptes scabi. Okay, it is Sarcoptes scabi. Okay, so this Sarcoptes scabi is the scabies mite. Okay, and this scabies mite, it is going to form a tunnel. In which layer of the skin does the Sarcoptes scabi form a tunnel? This is again very important. Again important MCQ. In which layer of the skin does the Sarcoptes scabi form the burrow or the tunnel? Okay. Anyone? Yes, but Sheikh, you have to be specific. You need to tell me in which layer of the epidermis does the Sarcoptes scabi form a burrow. This is a very important MCQ. Sanjay, you are right. It is epidermis. Sheikh, you are also right. It is epidermis. But I am asking you which layer of the epidermis. That is important. Okay, so remember that it is going to form a tunnel or a burrow in the stratum corneum. Okay, so it's going to form a burrow in the stratum corneum. Okay, and the fertilized female mite is going to lay the eggs, which are then going to convert themselves into the nymph forms, and then further they turn into adults. Now, what is the incubation period? The incubation period of scabies is up to a month. Okay, so remember that for a patient who is exposed to a scabies mite, the patient may not develop symptoms immediately. The patient is going to take maybe 3 to 4 weeks for the symptoms to begin. Okay, so the incubation period is around a month. What is the implication of this? The implication of this is that whenever you are treating a patient of scabies, you need to treat the family members, irrespective whether they have itching or not. Because even if they do not have itching, they may be in the incubation period, and 4 to 6 weeks later they will start with symptoms of itching, of papular lesions. Okay, and then they may be contagious to the other family members again, right? So that would cause ping pong scabies. One person gets affected, gets treated, the family members don't get treated, they start developing lesions later, then they again transmit the infection to the patient, right? So this is called as ping pong scabies. So like a ping pong ball, it comes and goes back forth. Okay, so ping pong scabies happens when you don't treat the contacts, and that is the importance, that even if the patient's contacts are asymptomatic, you need to treat the contacts because the incubation period is around 4 to 6 weeks. Now you again a very important question. What is the average number of mites? What is the average number of mites on the body of an immunocompetent individual having scabies? Average number of mites. Can anyone tell me what is the average number of mites on the body of a patient having scabies? Immunocompetent patient having scabies. What is the average number of mites? Anyone? Oh, Omkar, 3000 is too much. No, 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 no. I'll tell you why that does not happen. Sanjay, yes, you are right. It is approximately 10 to 15, average being 12. Okay. So the average number of mites is between 10 to 15, the average being 12. Now, why is it not 3000 as Omkar mentioned? Now, see what happens is when you are an immunocompetent person, when you get a scabies infestation, your natural response is to scratch. You will itch, right? You will have that sensation to itch and you will scratch. So, when you are scratching, what are you doing? You are trying to remove the mite from the stratum corneum. Stratum corneum is the most superficial layer of the epidermis, right? So definitely you have access to it. So when you are scratching, you are trying to remove that mite from the stratum corneum, right? So when the better the immunity that you have, the more the itch you are going to have. So the itch is not going to correlate with the number of mites. The more you scratch, the lesser the mites are going to be, and hence the average number of mites in a person will be approximately 12. In an immunocompetent person will be approximately 12. Okay, so please remember that the uh, number of mites and the severity of itch, they do not corroborate with each other. Okay, now let's go to a situation where the patient is immunocompromised. Okay, like for example, if the patient is having say HIV, okay, or AIDS. Further, if the patient is say is in a situation where the patient does not have sensation. See, if you do not have sensation, you are not going to scratch. If you do not scratch, you are not going to dislodge the mite. If you do not dislodge the mite is going to multiply, right? So in situations like say leprosy, okay, where you do not have sensations, or where you do not have central sensation of itch, Like for example, if there is dementia, okay, or if the patient is say mentally retarded, like say maybe in Down's syndrome, okay, or if the patient is not able to scratch, like the patient has the sensation of itch but there is some problem, there is paralysis say, and the patient is not able to scratch, then what is going to happen? You are not going to scratch, you will not dislodge the mites will multiply, and then there will be a point in time where you have the entire body which is teeming with mites, right? So that situation will present as psoriasiform psoriasiform appearance of lesions, especially involving the palms and the soles. So can you tell me what is the kind of scabies which has the maximum density of mites? What is that variant of scabies where you have the maximum density of mites? Yes, yes, as Raghu rightly mentions, it is called as Norwegian scabies. Okay, the other name for it is crusted scabies. Okay, so remember, in these people who cannot scratch or who do not have that perception of itch, they are going to be developing crusted scabies or Norwegian scabies, and on these people there are going to be millions of mites. Okay, now usually scabies is transmitted via contact, okay, and fomites. But in Norwegian scabies, the density of the mites is too high, and there can be even an airborne transfer of the scabies mite. Okay, so that is Norwegian scabies. If you have one patient of Norwegian scabies in your ward, the entire ward, including the staff, will need to take treatment. Okay, so Norwegian scabies is extremely infectious. So remember that in these situations you will have Norwegian scabies or crusted scabies. Okay, now another important thing that you need to remember about scabies is something that is called as the circle of Hebra. You know that scabies is characterized by the presence of a burrow, right? The burrow, as I mentioned, it's a tunnel which is made by the Sarcoptes scabi mite, the female Sarcoptes scabi mite within the stratum corneum, right? So that is the burrow, correct? Now this burrow you have to identify, and this burrow is pathognomic for scabies. If you identify a burrow, you have diagnosed scabies, correct? Now, so where will you look out for a burrow? The burrow you will see in the sites of circle of Hebra. So what is the circle of Hebra? It starts from your web spaces, right? It will start from your web spaces. So you look out for the burrow in your web spaces, then the wrist, then the medial aspect of the forearm, then the cubital fossa, then the anterior axillary fold and the axilla, then the periareolar area, then you will see it in the umbilicus, then you may see it in the groin and the genital area, then the perianal area, and then come back. So that is the circle of Hebra. Okay, so circle of Hebra defines where you will be seeing the maximum density of the scabies mite, or the maximum areas where you can isolate the scabies mite. Okay, now how do you make the burrow prominent? Okay, you are suspecting that there is a burrow, okay, but you're not sure. So how do you make the burrow prominent, or how do you visualize a burrow? See, one simple thing is you take a magnifying glass and then you look out for the presence of a linear brown line which will be suggestive of the burrow. If not, better you take a dermatoscope, you look out for the presence of the burrow. Or what you can do is you can take Parker's ink, okay, which is used in the ink pen, and that you place it over the suspected site of the burrow, and then you remove off the excess ink, and what you will see is a linear blue colored line because of the ink penetrating within the burrow. Okay, so that will help you to identify a burrow. Then remember, even a Wood's lamp is something that you can use to identify burrow in scabies. So tetracycline powder you apply over the suspected area of the burrow, and then you remove the excess powder off and then visualize it under a Wood's lamp. The area of the burrow will be appearing as a linear fluorescent line. Okay, so these are the methods by which you can identify a burrow of scabies. Now, another important point about scabies, how do you differentiate, or what are the differences between adult scabies and infantile scabies? What are the differences between adult scabies and infantile scabies? Anyone? Can someone tell me? Come on, Sanjay, Sheikh, Omkar, Raghu, anyone? Okay, now see what the difference is, that in adult scabies, the face, the palms, and the soles, they are not involved. Okay, so why is the face not involved? Because the face has sebum. Okay, and sebum is not something that helps the scabies mite. Okay, so that is why the facial involvement is not seen in adults. Palms and soles are not involved in adult scabies usually, because palms and so you are going to walk, right? So obviously because of the friction, because of the constant movement, the Sarcoptes scabiemide does not have a secure position, okay, for it to multiply on the palms and the soles. Okay, I'm talking about an immunocompetent individual here. So in adult scabies, you do not have involvement of the palms and the soles. The only exception being Norwegian scabies or crusted scabies. There you get thick psoriasiform plaques on the palms and soles, because here again, as I mentioned, the immunity is an issue. Okay, so in those cases, yes, but in an otherwise adult individual, the palms and soles are usually not involved, and the face is usually not involved. The implication of this is that when you treat the patient of adult scabies with permethrin, you tell the patient to apply the permethrin from behind the ear, from the chin down. Okay, the patient is not not told to apply permethrin on the face. But if you see infantile scabies, facial involvement occurs. Okay, because there is no sebum. Okay, now sebum comes in only when the hormones act, right? So in infantile scabies, you do have facial involvement, and you definitely have involvement of the palms and the soles, because the infants are not going to walk. The infants are going to keep their fists clenched, right? So they are going to keep their fists clenched, so that particular environment is very conducive for the Sarcoptes scabi to form a burrow and multiply, right? So that is why in infantile scabies, facial involvement, palms and soles are involved in infantile scabies. Also, in adult scabies, you most of the time see only papules, excoriated papules. While in infantile scabies, remember that in infants, the dermoepidermal junction, it is weaker. Okay, so that is why you will have higher chances of developing vesicles and bullae. So vesicles and bullae are more commonly seen in infantile scabies versus adult scabies. Okay, so that is again a very important fact that you need to remember. Okay, so please remember that there can be variations of scabies as well. As we mentioned, one was Norwegian scabies. The other variation that we discussed was scabies in babies, right? Scabies in babies. Then the other variation is eczematized scabies. Now, eczematized scabies can happen because the patient's itching and scratching. So there can be eczema which can develop over and above scabies, that is eczematized scabies. It can sometimes also happen because of the use of irritants in the treatment of scabies. So eczematized scabies is a complication. There now, can someone tell me what is the most common complication of scabies? What is the most common complication of scabies? What is the most common complication of scabies? Yes, very good, Sanjay. Secondary infection. So, secondary infection is the most common complication of scabies. Yes, secondary infection is the most common complication. Then another complication is nodular scabies. Okay, so what is nodular scabies? Nodular scabies, basically it's a hypersensitivity response to the scabies mite. So even after you treat the patient adequately, and even if you treat the family members, the patient presents with persistent itch and papules nodules over certain areas like the genitalia. Nodular scabies most of the times occurs over the scrotum, sometimes may happen over the penile shaft, sometimes can happen over the axillae, sometimes can happen in the periareolar area. Nodular scabies is basically a hypersensitivity response to the scabies mite, and hence the patient will have persistent itch even after complete eradication of the scabies mite. Okay, so how do you treat nodular scabies? See, you of course have to treat scabies. After you are sure that the patient is completely treated, then you can, if the patient is an adult, you can start with topical, intralesional steroids within the scabetic nodules so as to suppress the inflammation and suppress the itch. Okay. For a child, maybe you can start with the use of a topical steroid. You have to counsel the patient of scabies whenever you treat the patient of scabies that the scabies is might will die, but for your itching to completely disappear, it will take some time. It would take at least 4 weeks for it to completely go away. The reason being that your body has reacted to the scabies mite, okay, and for that reaction to settle, the inflammation to settle completely, it would take time. Okay, so that was about nodular scabies. Now, what you need to know is the treatment of scabies. Now, what is the treatment of scabies? The treatment of choice of scabies is 5% permethrin. How do you apply permethrin? The patient is asked to apply permethrin. In an adult, you ask him to apply the permethrin from behind the ear and then below the chin all over the body. It has to be left on for 12 hours and then it has to be washed off. Not only the patient but also the family members are to be treated, or the contacts need to be treated even if they are asymptomatic. Okay, now the 5% permethrin is also used in pregnant females and it is also used in newborns and infants. Okay, though the safest medication one can use in an infant is sulfur, but the sulfur problem is that it is going to stink and stain. For these disadvantages, it is now no longer used in the treatment of scabies. What you prefer is using permethrin. The other medication that is used in scabies is gamma benzene hexachloride. The other medication that you use is scrotamycin. Okay, you can also use malathion. Further, remember that there is a drug which is called as ivermectin. Ivermectin is used in scabies in the dose of 200 micrograms per kg. For an adult, average adult, you can give around 12 milligram tablet to be given. Say if you have it given it one today, the other tablet you need to give after 15 days. Okay, the ivermectin is going to work on the chloride channels. Okay, and that's how it will help in the treatment of scabies. Further, the treatment of Norwegian scabies is that you have to give repeated episodes of, repeated applications of permethrin with ivermectin, repeated doses, and you have to treat those psoriasiform lesions by keratolytics like salicylic acid. Okay, so that was about the treatment of crusted scabies or Norwegian scabies. Okay, so we have discussed a lot of important topics today. We have discussed scabies, we have discussed Wood's lamp examination, we have discussed tinea capitis. Okay, so I hope that is useful to all of you for the upcoming NEET PG examination. Almost all the MCQs which are important from this particular topics have been covered, and with that, I would like to say that please do join Unacademy. It is a very useful experience, and when you use the code mentor, you will get an additional 10% off. So with that, I take your leave. If there are any doubts regarding the topics that we have discussed today, you can ask me right now. Anyone? Sanjay, Raghu, Sheikh, Omkar? Anyone? Any doubts? Any questions? Okay, fine. So I end my session. Thank you so much. Thank you, Sanjay. Thank you, Sheikh. Thank you, Omkar. See you soon. Bye.